Hello, everyone. This is Susan from AMSUS. Thank you for joining us. We'll be starting in a moment. You can take this time to make sure your audio and video is working. If you'd like, in the questions box in your control panel, you can type in where you're signed in from. We have some international folks registered. It'd be nice to see how far we reach. And I'll be back in a moment to give a little announcement and start the program. In the meantime, enjoy the slideshow. All right, this is Susan from AMSUS once again. Thank you for joining us today. If you're having difficulty with connection or sound, you may want to close programs and browsers as they can use up bandwidth. You'll notice a control panel to the right of your screen. This is where you'll be able to type questions directly to the moderator and find handouts. You may type your questions at any time and they will be addressed by the moderator. A survey will be emailed soon after this event. Your feedback is both appreciated and requested. If you're not an AMSUS member and would like to join, visit amsus.org for a list of benefits and more information. And now, without further ado, I pass it along to Colonel Kimberly Beaver.
Hi, good afternoon, everybody. Thank you so much for joining us for Reflections on Oxygen 2023. I'm Kimberly Beaver, and I'll be your moderator for today's presentation. I'm a retired Army nurse who spent over 34 years in the Army. I've been a critical care nurse for about 28 years and a nurse practitioner for 23. I've deployed 3 times to overseas conflicts and spent time, about 10 years, developing the en route critical care program for the Army. I was the chief nurse of the Joint Trauma System and spent 4 years as the consultant to the Army Surgeon General for en route critical care. I recently retired from Brooke Army Medical Center after having served my last assignment as the Deputy Commanding Officer and Acting Commander for BAMSI. I'm delighted today to have the opportunity to talk with you about a very important topic and a gap that we don't often talk about. I'm also delighted today to have these 2 esteemed colleagues with me, Dr. Warren Dorolack and Dr. Joshua Quick. Dr. Dorolack is a trauma and acute care surgeon at Medical Center of the Rockies which is an ACS verified level 2 trauma center out in Loveland, Colorado, which is also part of the University of Colorado system. He's the vice chair of the American College of Surgeons Committee on Trauma and also serves as the medical director for pre-hospital trauma life support with NAEMT. Colonel retired Dorlac was on active duty in the Air Force for 26 years before retiring in October of 2011. He's had numerous impactful assignments and deployments, which one was with me in 2009 with the Joint Theater Trauma System. Dr. Dorlac is a fellow of the American College of Surgeons. Dr. Quick is an anesthesiologist and board certified in both anesthesiology and advanced perioperative transesophageal echocardiography. He is currently a cardiothoracic anesthesiologist with the VA Connecticut healthcare system. He's also an assistant professor of clinical anesthesiology at Yale School of Medicine. Commander Quick is currently in the Navy Reserves and serves as the officer in charge of Naval Reserve New England Medical's Detachment, NLC, based out of Groton, Connecticut. He's had deployments both on shore with Expeditionary Medical Facility, and that one was in Djibouti, Africa. And he's also been at sea with the hospital ship with the U.S. Navy Mercy during Navy's response in the COVID pandemic. Dr. Quick is a fellow of both the American Society of Anesthesiologists and the American Society of Echocardiography. Thank you both so much for joining us here today. This is an industry-sponsored presentation by Thornhill Medical and Moves SLC. So our learning objectives for today, we want to make sure that everyone understands lessons learned that have been out there for oxygen as a commodity. This really came to the forefront in COVID-19, but we've also seen it in natural and man-made disasters, so it's important to talk about that. We also want to explain how medical grade oxygen is delivered in our hospitals and out in the field. Explain the risks that we'll face in large-scale combat operations and multi-domain operations, and then we'll review some case studies and challenges that have existed during operational situations and before. So with oxygen as a commodity, it came to the forefront as being scarce really during COVID-19. Experts who have discussed this problem don't believe COVID is the reason for the oxygen scarcity, but that COVID just highlighted or uncovered the problem that already existed and really needs to be addressed. And many of my colleagues that I've talked to, I know, have talked about this being a significant gap in our field units, but that we don't really talk about it. An article in the British Medical Journal that was published on 29 March 2022 describes a situation where over 20 countries were seeing surges simultaneously in about 75% of the COVID cases. And really, the patient admitted to the hospital only needed oxygen for treatment. According to the World Health Organization in February of 21, more than 500,000 people with COVID needed oxygen daily, and many of these were in low and middle income countries. Hospitals were just simply running out of oxygen every day. A task force was established to address the oxygen shortage issue, and as medical professionals did not see the demand for that oxygen decreasing. So back on the home front in the US, Dr. Eric Toner from the Center of Health Security at Johns Hopkins wrote about problems with oxygen scarcity in the United States in January of 2021. Dr. Toner relayed to health officials and clinicians from California, Minnesota, New York. They all discussed not only the systems freezing due to the high flow oxygen delivery, but also old infrastructure that was not able to support the high flow oxygen needs of the patients. Portable oxygen containers posed an issue because timely delivery and then availability of the actual oxygen containers themselves in all sizes were lacking. So personally, my dealings with oxygen over the years pretty much revolved around, is the oxygen on the wall? Is it turned on? And I'm not seeing SATs improve, so what's going on with my oxygen? Also, when we plan for flights in the field environment, you had to make sure that you were taking into consideration how long your flight was and how many oxygen tanks you would need. Sometimes it was a litter full of oxygen tanks. But really, when I was a hospital commander, I had to truly understand where oxygen came from, because as we were planning for the pandemic, it became interesting when they asked me about expanding my hospital and trying to figure out how we were going to do that and where we were going to have the oxygen supplies that we needed. And what we found out was, even though I had a 264 bed hospital, most of the oxygen had been capped off to all of the beds, leaving only about 25 to 40 beds with oxygen capabilities. And it was going to cost a significant amount of money to reconnect all those oxygen pipes and get it running again so that we could have the bed capacity that we needed. The other issue is I asked, well, can't we just bring tanks to the bedside? Well, tanks weren't available and they weren't delivering them very well. So it was really highlighted for me as a commander that there may be a problem moving forward. So oxygen really is considered a prescription, and it's for our patients. And so as we move through this presentation, we're going to go through why it is that we need oxygen, why we need to have these conversations, and why we should be worried that there may be a scarcity in the future. I'm going to turn it over to AMSUS for our polling.
We have a poll launched that you can use your dashboard to interact with. We're going to leave this open for a few more seconds. We have about 50% of our audience have voted. We'd like everyone to participate if they can. And so far, we're up to 88% true. We're going to let it go for another couple of seconds. All right, let's see what our results are. And there you go. We have 91% true and 9% false. Back to you.
Thank you. So let's start off by talking about where oxygen is obtained, and I'm going to turn it over to Dr. Quick to help me with that.
Thank you. Good afternoon, everybody. Thank you for joining us today. I'm very happy to be here. My experience with oxygen, as mentioned, I'm a cardiothoracic anesthesiologist, so almost all my anesthetics have oxygen in some form being administered. But it wasn't really until I got out to my deployment in Djibouti, Africa, where it really took a forefront for me, because I was responsible for generating all the oxygen for the entire base, including the fire department, special forces, the hospital. We had no piped oxygen there. And to be honest with you, before I had to start doing that, I never even really thought about where it came from. So I imagine a lot of people are in the same shoes that I was in. So I thought I would just start off with, where does oxygen actually come from? So ultimately, pretty much all of the oxygen that we administer to our patients comes from the ambient air. We essentially grab it out of the air, we purify it, we compress it, and put it in for storage. If you're a true purist, for some of the audiences, I'm sure there are, all oxygen ultimately comes from stars. All the heavy elements are all made in stars, and the stars blow up and distribute amongst the galaxy. I just find that very inspirational to know that every molecule, every atom of oxygen I breathe came from some star somewhere. So as mentioned, so once we collect the oxygen, we generally purify it, compress it, and then it's stored for use. Most facilities will have some storage site on the facility grounds, and that's where the oxygen is going to come from. So most of us just think that we plug into the wall and there it is, but it actually is coming from somewhere at your facility. You can go ahead and advance the slide. Okay, all right, I'll bring in there. So for larger facilities, what you'll find is that many of them will use compressed oxygen in the form of liquid oxygen. So they'll have a very large tank that will have liquid oxygen in it, and then that's slowly allowed to evaporate to feed the central supply lines. Going beyond the topic of oxygen, but also just your other medical gases, airs, generally in larger hospitals, compressed by an on-site compressor that'll just take the ambient air, it'll purify it, run through some filters, and compress it up to the 50 psi that you're going to get out of your wall outlet. And then for the anesthesiologists like me, we always want to know where our nitrous oxide is coming from, and that's almost exclusively gotten from tanks, usually in some form of a tank manifold. If you look at this picture here on the slide there, you'll see that large white tank in the back. That is the liquid oxygen supply for this facility. And then you see a series of yellow tanks. That's actually medical air. They're actually using a manifold instead of compressor for this facility. And those smaller blue tanks in the back, that's the nitrous oxide manifold. Next slide. Smaller facilities, this is actually a photo from a facility I've worked at before. It's a small 2 operating room surgery center, ambulatory surgical center. And they exclusively use tank manifolds generally. They generally will not have a large liquid oxygen tank. They will not have on-site compressors there. They essentially get all their gases through tank manifolds. You notice the blue ones for nitrous oxide here, and the green ones in the back are the oxygen. If you look right in the lower corner there, you can see a little yellow tank. They have little small E cylinders for medical air at this facility. Next. You want me to continue on with this one too?
Oh, I can take this. So with our oxygen sources, one of the things that we wanted to make sure that you understood is that there's many ways that oxygen is delivered to your hospital. So when we talk about reliable oxygen delivery, there was a task force that was generated that I told you about earlier. It's called the ACT Accelerator Oxygen Emergency Task Force. And that was established in February 21 to tackle some critical problems that were occurring. The task force looked at ways that medical oxygen is available, how we make it reliably available across the globe. The World Health Organization in August of 21 gave the ACT task force $1.2 billion to address this critical oxygen need and help treat those that were seriously ill from COVID. So when we look at these delivery methods of oxygen for the hospital, the liquid oxygen is really the most cost effective. It requires storage of a cryogenic liquid in large containers and the system of pipes to be available to deliver that transformed gas to the bedside. A more expensive oxygen delivery method is called pressure swing absorption, and it's built into some hospitals. This too requires a system of pipes to deliver it to the bedside. And Dr. Quick will talk a little bit more about how that really works in a little bit. Some hospitals do have their own plants which extract oxygen from the air to delivery to the bedside. Some oxygen cylinders, which really are the most expensive option, those oxygen cylinders that we all tend to rely on, they can sometimes cost 10 times more than liquid oxygen and require much more frequent refills. Oxygen concentrators are also available out there, and they're small, low-cost devices. They pull air in from around them and filter it out. They filter out the nitrogen and allow delivery of high concentrations of oxygen to the patient. The use of oxygen concentrators has really grown significantly over the past couple of years. Another device that we have in industrial settings are the portable oxygen generators. And again, Dr. Quick is going to give us some more information on the portable oxygen generators. And then lastly, what we use on like aircraft and submarines and out in space are chemical oxygen generators. And those have a sodium chlorate pellet in them, and when that ignites, because there's an igniter attached to it, so whether it's through pressure or it's tapped, when it's ignited, you get a reaction with that sodium chlorate, and that decomposition that takes place, it doesn't really burn, but the decomposition that takes place gives off a lot of oxygen, and so you get high concentrations of oxygen from that. These next couple of slides, I'm just gonna move through those quickly so that we have plenty of time for the rest of the talk, but they'll be available to you. These slides really just show other oxygen sources that we have that are out there. Many of these that we use in field settings currently, and we've used them in the past. And you'll see that there are many different ways of generating oxygen out in the field. Part of the frustration with that is there's many different ways to generate oxygen out in the field. Some of them are truly reliable, some of them not as reliable in the field environment. So we'll move on to our next poll.
Okay, we have poll 2 open. give the audience some few more seconds to hop in and register their response. We're getting a high percentage of maybe so far. We're going to give it another couple of seconds. All right. And here we go with our results. The high 57% with the maybes. Even 22s for the other two. Back to you.
Yeah, I'll just, this is Warren Dorlack. Again, thanks for the invite from Dr. Quick and myself to participate, Dr. Beaver. It's a topic that I think a lot of us have to deal with every day. I think the audience's response there was a good one, maybe, right? So we don't know what kind of situation we're in. If we're in something where, such as the Ukrainians are involved in now, it's going to be a different story than if we're talking about what oxygen do we have in Somalia during maybe an event such as like Black Hawk Down. So I want to talk a little bit about military use and some of the work that has been done by the DoD in terms of looking at oxygen. And first of all, it is not something that we take to the point of injury. So in tactical combat casualty care, the first places that you identify oxygen use are really in tactical field care and tactical evacuation care. And that's very different from a civilian ambulance who may be taking oxygen right to the scene in their ambulance. We have oxygen available at our Role 1, Role 2, Role 3s in theater, and then it's available on aeromedical evacuation. Next slide. The tactical combat casualty care guidelines have been updated since the 1990s, and this is the most recent reiteration of that. And so for tactical field care, so not under care under fire, but tactical field care, the next sort of phase, here it's recommended for oximetry, and then really the only people giving oxygen to would be maybe if you have it, to somebody with severe traumatic brain injury that has a oxygen saturation that's less than 90%. Next slide. As far as evacuation care, the list gets a little bit larger. And so there, the platforms typically have the ability to bring in oxygen, whether it's on a helicopter, whether it's on an ambulance, or whether it's on a fixed wing. And so you can see a list of the recommended TCCC casualties who you should be considering oxygen for. And I'll just mention a couple of them, and we're going to talk quite a bit about casualty at altitude. So a lot of our time is either spent at altitude or going up in altitude or passing over a mountain pass that takes you to altitude. So we'll talk a little bit more about that one there. This known or suspected smoke inhalation is one I showed an original slide from 1996. This is one that has been added since then, but otherwise they really haven't changed too much since the TCCC guidelines have been in play. Next slide. So what are our concerns about use of oxygen? You know, why are we not taking it forward on the battlefield, or why are we concerned about having it at a forward setting? Well, one, it's a finite resource, so it's going to run out. So if you have the ability to make your own, that may be better. The carrier for it, using these heavy oxygen bottles, it's heavy. It's very cumbersome. Having flown in this Black Hawk right here with large cylinders on board to manage one patient that was profoundly ill, I can tell you, it's super challenging to be moving these containers with your patient back and forth. It's bulky, take up a lot of space. That's why the medics aren't carrying it. It's heavy. There is a fire risk to the surrounding area. So if oxygen helps feed a fire, so that's always a risk. And then if it's injured, if you're using a bottle specifically, and that is injured, it can turn into a projectile. In addition to those concerns, there's the significant concerns of cost, trying to, just like fuel, trying to bring fuel into a combat zone. Transporting adds a significant cost. There's a maintenance that goes to maintaining these systems. And then there's a huge logistics tail, especially for bringing in and out of theater the oxygen. Next slide. I think that one's yours,
Okay,
Tim.
I'll take over here. Yeah, so as we were saying before, oxygen really should be thought of as a medication that we prescribe and administer to our patients. And as we've seen recently with the pandemic, they're going to be quite critical in ensuring survival and good outcomes for our patients. The issue really arises in austere environments because the supply chains are very, very tenuous. We've already talked about some of the difficulties with bringing oxygen into a combat environment. Simply being forward deployed in undeveloped countries, oftentimes they just don't have the oxygen, they don't have the supplies to give you. Oftentimes they're looking from us to get supplies, various medical supplies. Also, natural disasters certainly can interfere with our supply chains. And as we saw the global pandemic, I mean, essentially all of our transportation was shutting down there. We're having problems with all kinds of supplies, up to and including oxygen. So the ability to resupply oxygen and minimize your waste and loss is really crucial to administer effective patient care. Next slide. So this is an example of something that we're currently using in the field. This is known as a portable oxygen generator, the POGS 33C. I've actually had the pleasure of using this more than once. It's my duty, as mentioned, when I was in Djibouti, I was the oxygen generation officer, and this is actually how I was able to generate the oxygen. So this machine is capable of taking ambient air and purifying it to 93% pure oxygen plus or minus 3%, and it can provide that oxygen at flow rates of up to 33 liters a minute at a pressure of 50 psi, which is your standard wall outlet pressure. It's also capable of providing medical air. It essentially just compresses air and filters it and provides it at 50 psi at a rate of 20 liters a minute. It's got 4 oxygen outlets, 3 air outlets. With an optional booster, you can actually plug in one of those oxygen outlets into a booster, and it can pressurize cylinders up to 2200 psi. So in the facility I was in, we didn't actually use piped-in oxygen. What I would do is I would fill large cylinders, large H cylinders, up to 2200 psi, and we would bring those into the operating room, into the patient care spaces, and that's how we provided oxygen. This system comes with 2 main components. There's the compressor, which is quite loud and needs adequate ventilation in order to get the air, and then this machine that you're seeing in the picture is the actual generator. Next slide. So how does it work? This is the real interesting question there. It's really quite fascinating there, but it is actually ultimately quite simple. So it works on a molecular sieve concept. So if you think about taking a sieve and just running sand through and collecting pebbles, you're doing the same thing, except the zeolite material that's in these sieves has micro pores in it that can actually capture atoms of nitrogen predominantly, and let the oxygen pass through. So essentially how it happens is the compressor will take in the ambient air, pressurize it, and then it'll deliver it to the oxygen generator. That was the big device we were looking at in the previous slide. The oxygen generator will have 2 sieves, and it'll use one at any given time. And it will begin filling the sieve, letting the air run through. As the air runs through, the nitrogen is trapped inside the pores of the zeolite material, and the oxygen is allowed to pass through, and again, can get up to around 93% pure. Eventually, that sieve is going to fill up there, and it's basically done on a timed circuit. So the generator says at this pressure and flow rate running through the sieve, in this time frame, the sieve essentially should be full, and then it'll essentially switch to the other sieve and begin using that one. As one sieve fills, it bleeds back some of the pure oxygen, not just to the outlets, but to actually wash out the previous sieve. And it just swings back and forth. So the air is going through one sieve, being filtered out there, and as it's filtering that oxygen, it's blowing out the previous sieve, all the old nitrogen that was in there, and that just gets released into the ambient air. And it just keeps switching back and forth, and that's how it can continuously give pure oxygen. Next slide. This is actually my generator. So this is taken in Djibouti. You'll notice the third picture from the left is the compressor. It is outside because it's incredibly loud. So you never have kind of inside patient care spaces. We generally locate that outside, and that gives it plenty of flow to air. Then the compressor feeds into the generator. That's the leftmost picture there. And that's the one that actually does the swing absorption and actually generates the oxygen. You'll notice I have a green hose connected to one of the oxygen outlets. And if you look at the second picture there, that green hose is actually coming down the wall, and that is the booster that I was mentioning. And that booster is plugged into that large H tank, and I am pressurizing that tank, again, up to 2200 PSI. If you look at the bottom picture there, that's my oxygen meter to make sure how much oxygen I'm actually generating there. And at that time, I was generating 91.2% pure oxygen with that generator. The picture you see on the far right there is just another configuration. So this is actually from a training exercise. Same machine. We had the compressor outside, as mentioned before, so it had plenty of flow of air, and because it was so loud. But you can actually have the generator itself in patient care spaces. So that's actually our operating room in one of our field hospitals, one of our 10 hospitals. And we actually had piped in the medical air and the oxygen right into the anesthesia machines, and we ran them just right off the generator inside the operating room. This is kind of the newest thing that's coming out in the field on the Marine Corps and the Navy side. And this is the MOVES SLC. What the MOVES SLC is, it's really outstanding technology. It is essentially a self-contained ICU, for lack of a better term. So it has a few components to it. It has its own oxygen generator that also works on the sweat absorption cycle, kind of like a personal oxygen generator of the POCs that we were just talking about. It also has the ability to ventilate patients. So it has a built-in ventilator. And it has a fully capable monitoring system. So we can do EKG, pulse oximetry, blood pressure. It can do invasive monitoring. So you can do CBP, PA pressures, arterial pressures. It really can do everything. For anybody anesthesiologists out there, the addition of another device that you'll see, and I think there's some subsequent pictures there, the MADAM, which is essentially an anesthetic gas blender. When added to this, oh, there it is right there. You can see the small box and the two pictures that kind of has the glowing bottle there. That's the MADAM. That added to the MOVES SLC essentially makes a fully functional anesthesia machine. Really incredible technology. This device is designed to travel with the patient. So you basically would start the patient on it if they need this level of care there, and they can transport in whatever vehicle they're going with. You can just attach it to their stretcher and move it along with them. And the ventilator, just so you can see there, it's able to give up to 85% pure oxygen in ventilated patients. If you're not ventilating, just using it kind of like a supplemental, like nasal cannula, it can be up to 93%. It can flow at about 2.5 liters a minute. So a smaller oxygen generator, but it is capable of doing it. Next slide.
We'll poll the audience again to see where we are as far as our understanding of protocols that are used.
Here's our third poll. All right, we've already got about 60% votes in. We'll give it another 4 seconds. Large percentage of false responses. Give it a few more seconds. Give it, there we go. And let's go to our results. 79% false is the high number here.
Okay, great. Thank you. So now we're going to move on to talking about really our how we mitigate the loss of oxygen through either the choice of our patients or protocols that tell us how much we should be using.
All right, this is going to be some of the more controversial things I'm going to say, but this is actually kind of real world scenario type thinking, because the expectation is that our next major military conflict is likely to be near peer, and therefore the ability to have total air dominance is likely not going to be an advantage that we have, which means that casualties are going to be kept on site for long periods of time with limited resupply. So these questions do come into clarity when you start thinking about how you're going to plan that out. So when it comes to mitigating oxygen loss, because you may have the supplies what you have and you want to try to extend as much as possible there, the first question you should always ask yourself is, does my patient need oxygen? Here in the States, when we have almost an unlimited supply, it seems that time there, we give oxygen willy-nilly, just throw nasal cannula on, 2 liters a minute, 4 liters a minute. A lot of our ventilators are driven off of oxygen through the bellows. And we just don't think about it. But when it comes to being forward and not having those unlimited supplies there, you're going to need to be careful in your selection. So just as a reminder, humans only extract about a quarter of the oxygen in the air for every breath that we take. This is why mouth-to-mouth resuscitation can keep people alive, why mouth-to-mask resuscitation keep people alive, because you're expiring the air that you breathe, but there's still actually quite a bit of oxygen in it that another person could use. So we only extract a small amount of the oxygen in the air to begin with. So you actually do have oxygen pretty much readily available. It's ambient air. The question is, do you need more than that? Do you need enriched oxygen? Probably, again, the most controversial thing is, I'll tell you, and I want you to think about is there that truth is that most patients do fine even in the low 90s%. And to give you a few kind of real world examples there, patients with sleep apnea, if you ever look at their sleep studies, one thing that's calculated out is how much time do they spend below 90% there. And some patients spend a significant amount of times when they're sleeping below 90% without any kind of significant sequelae. Long term, obviously, you're going to start having problems. For the short term, just their sleeping periods, they're all right. Another example is lung surgery. I was just doing lung surgery today. These patients tend to have very sick lungs, and basically turn one lung off so it can be operated on. We're just operating on and ventilating on one lung. It is not unusual for these patients to spend several hours in the mid to high 80s, and we just can't keep them in the 90s. And again, they survive. They're able to do fine there. Now, I'm not advocating, I don't want to get misconstrued. If you have the ability to keep people in the 90s and high 90s, I'd love everybody 100% oxygen saturated. But when push comes to shove, you need to look at the salt of the whole patient there, not just one number, but think about, okay, how is this? Are they showing signs of low oxygen? Are their hemodynamics stable? Are they maintaining appropriately? Do they have any signs of end organ ischemia? And that's really what needs to guide your administration of oxygen, not just simply a saturation number. Next slide. Beyond patient selection there are several things that you can do besides administering oxygen or improve people's oxygenation. This is something we use quite a bit. Patients on ventilators there, but simple recruitment maneuvers and playing around with the end expiratory pressure, positive end expiratory pressure, or PEEP, just to maximize the surface area that's available for exchange. A lot of times people are hypoxic because they're essentially shunting. There's blood that's going through the lungs that's not coming in contact with oxygen, and it's going back into the system. That's what's dropping your oxygen saturation. If you can simply keep able to recruit those alveoli that aren't participating, you can actually quite significantly improve oxygen saturation. This is a common problem in the operating room, and we use this technique to very good effect. For patients who are not on ventilators there, simple things like incentive spirometry, just having them take these deep breaths, yawning breaths to, again, recruit the alveoli, maximize your surface area for exchange. And a lot of times that'll take care of your problem well enough that you don't need to give supplemental oxygen. CPAP is another thing you can do to help keep those alveoli open for people who are continuously kind of de-recruiting in a way, people who aren't taking very big breaths, maybe splinting because pain. These are things that you can do to kind of maximize your surface area. Also positioning, we kind of learned this during COVID. If there's certain areas of the lungs that are not participating in gas exchange, maybe you can move the blood to other areas of the lungs that are participating in the gas exchange. Proning is an excellent example. We found during COVID that patients were having these pneumonias, and we could change their position so that blood would preferentially move to the bare aerated portions of the lung, that would actually improve their oxygen saturations and their outcomes. And then something that's often glanced over there, but so your blood's ability to carry oxygen. Oxygen that's absorbed in the liquid portion of the blood is very, very small. Hemoglobin is the primary deliverer of oxygen in the body. So patients who have very low hemoglobin, you may find that their saturations are suffering because of that, but that's a carrying capacity delivery issue, and it doesn't necessarily need supplemental oxygen as much as you need to restore that carrying capacity. I've actually seen this real time in the operating room when people were hemorrhaging and their saturation suffer because of that, and simple blood transfusion corrects the problem. Next slide. So minimizing loss. So one thing I want everybody to think about is just minimizing flow. Again, it's very easy here in the States that we turn on the flow meter, 4 liters a minute, 10 liters a minute, we don't even think about it. But the ability to kind of go low flow and really target your therapy. Think about, what are you trying to achieve? Are you just trying to achieve a number? Or are you trying to achieve some kind of clinical effect in the patient, and really guide it towards that? A lot of these things I've listed here are things that you may not readily have available, but if you're in the planning phases, or you're thinking about I'm going forward, or my hospital is preparing for contingency operations there, these are things that are worth exploring there. So anesthesia machines, and there are ventilators for ICU patients as well. Anesthesia machines in particular that were designed to be closed circuit systems that allow you to go low flow. The biggest barrier to low flow with most ventilators is just the CO2. If you're going so low on the flow, people just rebreathe their CO2 and they become acidemic and hypercarbic. So the anesthesia machines actually have CO2 absorbent. The same concept is used in rebreathing scuba diving. Basically, you can go very low flow. You just take out the CO2, you can rebreathe the oxygen and you breathe out. You can rebreathe instead of gases, but you have to have ventilators that are capable of doing that. Your ventilatory sources. This is a huge user of oxygen. Most ventilators use pneumatic bellows, and pneumatic bellows runs off of generally oxygen, and they can use up to 7 to 12 liters a minute of oxygen just to run their bellows. Ways to get around that: there are ventilators that have electronically driven bellows that don't use oxygen at all. Draeger makes an SDU machine. Almost their entire line is actually electronically driven now, and it's capable actually of running, and just it can train regular ambient air and use that to ventilate the patient. So that's something that can be considered. Some ventilators, I believe the GE ones, allow you to actually change the driving gas. So you don't have to use oxygen. You can actually just use compressed medical air and not have to use your oxygen. So if you have an air compressor, you could actually reconfigure those ventilators to use compressed air instead of oxygen. And then it seems so simple, but a simple ambu bag. If you really need to ventilate somebody, you don't want to waste oxygen there, if you have the people and have extra hands, people can sit there and they can bag the patient. That's certainly can be done in the short term in order to spare your oxygen supplies until you can get the patient to a better situation. And then just consider your gas sources there. You know, oxygen is not the only gas that can be used on patients for ventilation purposes. You can use medical air, you can use ambient air, for example. An ambu bag can draw in ambient air, and you can use that to ventilate the patient. If it's just a ventilatory drive problem, oxygenation problem, that's likely all that you need, and you don't have to use your oxygen supplies to drive a ventilator. Next slide.
So I'm going to switch a little bit and talk about some of those risks of hypoxemia. So, and we're going to also look at some of these studies that do show that actually the majority of our casualties probably don't need any oxygen at all, especially early on. But what are the risks of leaving a patient hypoxic? We know that there is an association, and it's been shown in over 6 studies now, that there is an increased risk of death and disability in patients with traumatic brain injury. All these are observational studies that we've not randomized. No one has ever randomized patients. So really it's an association, but it's a very strong association. We'll show one of those studies. Tissue hypoxia can lead to increased wound infection in aeromedical transported, at least in animals. We've seen that. We've speculated that in the Air Force for a while. And we have shown that in an animal model that actually does work out to be true. There is a generation of lactic acidosis with low oxygen level. And then the final thing, and we'll talk about this as well in another study, and that is your risk of hypoxemia is significantly worse when it's coupled with the hypotension or poor perfusion or or a low hemoglobin count, as Dr. Quick just mentioned. Next slide. So who requires oxygen? This is an animal study done by Air Force Ryan Ernest when he was at Cincinnati, and it showed that they were able to demonstrate that supplemental oxygen, giving in a goat model through an attenuated or through a aeromedical evacuation simulated flight, so taking them into the altitude chamber, actually giving supplemental oxygen attenuated the increase of bacterial growth in a sort of complex wound model. Next slide. And this is a study that's really ongoing. This is an observational study from Arizona, and it's called the EPIC study. It's the Excellence in Pre-Hospital Injury Care. And really what they've been focused on for almost 10 years now is looking at the impact of management of pre-hospital traumatic brain injury. And as you can see, over 13,000 patients in this. This is from 2014 when they first started analyzing their data. They have this ongoing project. But what you can see is that if you looked at those patients that were neither hypotensive nor hypoxic, that was the bulk of the patients. But those patients with a TBI that hypotension only, small number of patients, hypoxia only a small number of patients, and even smaller number of those patients that both hypotension and hypoxia. But if you look at the mortality of these cohorts with no hypotension, no hypoxia, 5.6% mortality, and it extends all the way up to 43% mortality if they had both hypotension and hypoxia. Next slide. So this is the source for that publication, which came out in 2017. And really what they showed, and again, this has been shown in about 5 other studies, is that the adjusted odds of death in patients that had both hypotension and hypoxia was more than 2 times greater than if they had just had one of those alone. So as Dr. Quick mentioned, I mean, having hypotension, having low perfusion, and you combine that with hypoxia, clearly makes a difference. Next slide. This is another great study. It comes out of University of Cincinnati. And really the idea was to try and determine in trauma patients, how many patients actually really need oxygen. And the Cincinnati group, coupled with the Air Force group that's there, has really taken on studies of a number of studies looking at oxygen concentrators, looking at mechanical ventilation in altitude and not altitude, and trying to give us some answers. So in this study, they looked at 154 trauma patients that came into the university hospital that was activated. They had a trauma activation of some sort that was generated. Most of these were blunt trauma, but a good percentage, 36% of them, have penetrating injury. Next slide. This is just basically the big summary slide, but what they demonstrated was really only 30% of the patients that came in to the hospital had a SAT that was less than 90%. What they did determine was that about, so that means, you know, roughly 70% fall into that other group. The amount of oxygen that was required was difficult. This was all based on EMS protocols, and sometimes patients were given more oxygen than they potentially needed. They also took a breakout of the civilian penetrating injury patients and those patients with severe chest trauma, and found that actually their oxygen requirement wasn't significantly different. But it was really a good study to try and start looking at and capturing pre-hospital data and trying to give us, again, a few more answers. Of those patients that, again, it was about 34% of the patients had relative hypoxia with a saturation less than 90%. One thing that they did show also in this group was that those patients that received more oxygen tended to be older, and they tended to have a higher injury severity score, so they were more injured. Next slide. This is another interesting slide, a study that was put on by the group at Cincinnati. And what they wanted to look at, and this came out of basically experiences that medics were reporting at the TCCC, or their Tactical Combat Casualty Care meetings, that patients at going up to altitude, flying over passes in Afghanistan, they noted would become a little bit lethargic and they weren't acting quite normal. They'd drop back down out of altitude and the patients seemed to get better. And we're wondering, hey, is there something going on with these walking wounded? So typically on aeromedical evacuation flights, they're not on oxygen and they're not actually getting their pulse oximetry measured. So this was a monitored setting in patients that were being flown, but that were not super critically injured. Again, they walked onto the aircraft. And they looked at 61 subjects not receiving oxygen. And what they saw was that there was about 4% of the patients had a drop in their decrease in their SAT. But if you looked at overall, about 90% of them dropped their SAT below 90% for portions of the flight. So a big number there. Next slide. This was completely unexpected to us. And if you look at the longest periods of hypoxia, again, walking wounded, a SAT less than 85%. The longest SAT that was measured was went on for lowest SAT rather was measured went on for 44 minutes. So again, we were quite surprised by this, and it really made us think about, you know, what do we need to be doing for monitoring patients, and do we need to be using more oxygen on the aircraft than we are? Just a reminder, these aircraft are pressurized, but they're still at a higher elevation than the ground level that they're taking off them. Next slide. This next slide is just a graph showing that the bulk of the patients fall into that yellow box there where they were hypoxic for some period of time. And then you can see the duration of time in patients that had a SAT less than 85%. Still a pretty significant number. Next slide. And then finally, this study was done by Steve Barnes, who's now the chair of surgery at the University of Missouri. And what they did is they took patients that were flying out of Iraq, headed to Germany, and they were monitored. These were all CCAT patients, 22 patients, and everything about their ventilation, oxygenation was monitored and then captured on a laptop computer. So the laptop was hooked up to both an oximeter as well as to the ventilator, and they were able to assess throughout the flight changes in oxygenation, changes in how many manipulations were done to affect either PEEP or to change the FiO2. If you look at what I've got highlighted here, this is the injury severity score. These guys were severely injured. Every one of them excuse me, not every one of them, but the bulk of them fall into the major severe injury category in terms of their injury severity score. Next slide. Here's the data from that. And I think one of the things that, again, that surprised us was that despite how injured these guys were, and despite them all being mechanically ventilated, there were actually very few that required large amounts of oxygen. And the ones that did required an excessive amount of oxygen. But the majority of patients could be managed with a much lower flow oxygen. So again, kind of going back to what Dr. Quick said, they need a little bit, maybe they don't need too much. The walking wounded, we found even needed a little bit, right? But here we found that we could ventilate a good portion of these. Almost 70% of these patients could be managed with a lower flows. And that is something that could be generated from an oxygen concentrator, for instance. And that was why we looked at that number of less than 3 liters per minute. Next slide.
Thank you both very much for all the wonderful information. And considering, what we've discussed today, I think we can all agree that oxygen is a commodity that has a high probability for scarcity in the future, and that we need to make sure that we understand where it comes from, how we deliver it to our patients, and then how we educate those people that are going to be providing oxygen in the future. Most people don't necessarily need oxygen, but they definitely may not need high flow oxygen. We may be able to use more of a low flow oxygen. Because if you look at the quote up there from Richard Branson, who's one of the RTs, that Dr. Dorlak says is the smartest person that he knows, oxygen is like Goldilocks in medicine. We don't want to give too little, not too much, but we want it to be just right. And so ensuring that our medical personnel and our medics, caregivers, that we're taught how to conserve oxygen and what patients truly require oxygen is going to be important as we move forward. We, as healthcare providers, we have the responsibility to properly plan for and use our evidence or use our oxygen through evidence-based protocols and our clinical practice guidelines. And so our guidelines in the future definitely need to help our day-to-day care, but also care in a pandemic or during wartime. And understanding, as we have a better understanding now of our oxygen delivery systems, we know where we can get oxygen from and how it's generated, and then how we put that into practice and how we can reduce waste in the future. So as we look at the future, some closed loop control of oxygen may help assist with this goal of targeted oxygen saturation and give us optimal results for our patients. So I would like to go now to our discussion or questions and answers. If you have questions, please type them into the chat box, and that will we'll either get them answered today or we'll answer them. We'll get back to you within the next couple of days. But to get started, I do have one for both of you. And so as we've talked about, it's important to understand the different disease processes and illnesses that may require oxygen and how we need to teach our medics in the future. Do you have any idea of can you provide us with some of the information on illnesses or injuries that are common in deployed environments, where we would typically use oxygen as a medication because it provides better outcomes for the patients.
Yeah, I'll start off on that, and then we'll let Dr. Quick jump in. Yeah, I think it's a good question, and I think based on some of the studies, though, that I just talked about, I think in general, we don't have a really good idea of who really needs oxygen and really who doesn't. So I think the first thing for the medic is be measuring people's pulse oximetry and put an oximeter on the patient and monitor them, and especially if you're thinking about going up in altitude, because we've all been surprised at how many patients do require oxygen. In terms of injuries, certainly the one that's the sort of longest standing one is traumatic brain injury. We showed a couple of work there. There's a lot, like I talked about, a lot of great work that's coming out of University of Arizona with their EPIC study that's giving us more and more information in the pre-hospital setting for TBI, but it clearly makes a difference in that patient population. We do feel that blast lung injury is another population that probably early on needs more oxygen support. And then something we didn't really talk about, but is in chemical warfare, especially with chlorine gas, those patients have a horrific lung injury and will likely need oxygen very early on. We have burns, close space burns, especially aboard Navy ships. And we see those a lot in terrorist activities, another place where patients are likely to end up on oxygen very early on. Over.
Yeah, I'll jump in as well there. I agree with Colonel Darlack. I find the biggest problem with determining who needs oxygen is that it's not actually the oxygen on the pulse oximeter or what's in your lungs there. It's what's getting out to the level of the tissue, which is incredibly hard to measure. So if I was trying to advise my corpsmen, our equivalent of medics, is kind of what I alluded to before, is that you really have to take in full gestalt of the patient. How are they behaving? The brain is a very sensitive indicator of hypoxia. When I was in flight surgeon training, one of the things they did is they took us in the altitude chamber and took us up to 37,000 feet to take off your mask and make you do a little, toddler type test there, and you can't do it. You can't even think because your brain's very sensitive to those effects. Yeah, I would advise people when you're trying to determine who needs oxygen to really take a look at the full picture of the patient. Are they showing signs that their oxygen isn't adequate? Mental status changes, or are they cyanotic? Do they have evidence of they're not making urine anymore? There's something where their oxygen's not being delivered. You're having end organ problems because of that. Common injuries. I mean, we obviously focus on trauma a lot in the military. Certainly chest trauma, it always makes me think that they're going to have a high likelihood of needs of supplemental oxygen. And I agree with Colonel Dorlat, burn injury is the first thing I think about because those actually tend to present a little late. Somebody was in a close space fire, be caught on fire, fireboard ship, and they come in and they look fine, but within the next 12 hours, there's a very high likelihood they're going to get significant edema and have a lot of difficulty exchanging gas there. So those patients have a very high level of suspicion to have adequate oxygen supplies, they're likely to need it.
Yeah, it's also the treatment in the burns, treatment for carbon monoxide poisoning, which we don't have a really good way of detecting probably at the scene. I think you bring up some really good points in terms of the perfusion. So an oximeter may not necessarily be as helpful as we think it is in patients that are hypotensive, or if they have a super low hemoglobin. So a couple areas that you got to be worried about.
Outstanding. Thank you so much. And then one more question. Do either of you have any recent or past experience with conservation of oxygen due to resupply issues or concerns that you wouldn't get resupplied?
I'll jump in first on this one. Fortunately, again, when I was forward deployed in Africa, we had the ability to generate oxygen. So my biggest concern was the machine was going to go down, but I did have a backup machine. We weren't getting supplies from the local community, and most of our medical supplies would take 4 to 6 weeks to come from Germany to get to where we were. So I would try to use lower flows because I knew that the machine broke down, but we did have the ability to generate, so it never ended up being an issue for me. I tend to be just a low flow purist in general because I try not to be wasteful because all the stuff comes from somewhere, it all costs money, and I try to be as efficient as possible. And there are issues that come with using higher flows of oxygen. You know, people don't think about it that much, but oxygen is very dry. And it dries out people's airways. It's also very cold when it comes out there, so it can cool people down. We actually use special devices that humidify oxygen and retain the heat and moisture when we have patients on ventilation in the operating room just because of those issues. So I've never had to mitigate because my supplies ran out there, but certainly just in general, I try to be as efficient as possible, which helps with that.
I mean, we've had issues with certainly in CCAT. Where you know, if you either hadn't calculated your oxygen supplies correctly, we've had teams get into trouble in critical care transport with that, and I know that's been an issue for even some helicopter transports in patients that needed oxygen. I've never been in a forward facility where we didn't necessarily have oxygen. But you know, the kind of conflict that, if you imagine what the Ukrainians are going through right now, you can definitely see that the ability to maintain a big, heavy logistics tail to transport oxygen in and out is going to be super challenging, if not impossible for them.
Thank you both. And I think that that's one of the things that we have to think about as we think about the future global war and these large scale combat operations that we'll have is really how will we get the resupplies if we don't have air superiority, and will we be able to get them to the places that we need them, especially when we're talking about prolonged field care and people being out for up to 96 hours before they receive any resupply or any other assistance. So I appreciate that very much. We're at 12:01, so we're gonna go ahead and wrap this up. I want to thank very much Thornhill Medical for sponsoring this today. I think this has been very informative for our group, and hopefully everybody takes something away from this.
Okay, thank you so much. This is Susan from AMSUS. So thanks again to our moderators, our panelists, and of course our audience members. We hope to see you at a future AMSUS event. The slides and recording may be available upon request. If you want either, email membership@amsus.org. And it may take a couple of days, but we'll get a response back to you. All those great questions that came in, and we ran out of time, Thornhill will be seeing those questions and comments, and they may get back to you on a one-on-one basis. So once again, thank you for everyone. And on that note, I'm going to ask my colleague Lori to please close out the program.